In Chapter 6, I actually have good news for you. We are finally looking at a CNS chapter that will make sense, literally, because we are going to talk about dopamine and its role in the drugs used in Parkinson's disease, as well as the drugs used in treating psychosis, in particular the major form of psychosis we refer to as schizophrenia. If we're going to talk about dopamine for the first time since the past several hours you've been reviewing CNS with me, we actually have discrete pathways that use this neurotransmitter. We are back in a situation where physiologists have actually studied the effect of dopamine, where anatomists have identified pathways that use dopamine, and where chemists have really been able to identify every aspect of the pathways, a little bit like in the autonomic nervous system or the cardiovascular section. So if you have a good understanding of the next page on your book or the next couple slides here in the presentation, then you'll be able to literally understand what agonists are expected to do and what blockers are expected to do. Let's start with the historically most relevant pathway where dopamine has a role, the nigrostriatal tract. It means the cell bodies of these dopaminergic neurons are in substantia nigra in the midbrain, in the pars compacta, and their output is in the striatum, a group of nuclei comprising primarily of caudate and putamen. It is well established that Parkinson's disease is a pathology where there is a loss of dopamine neurons in this tract. And it is that loss of dopamine neurons through an imbalance with acetylcholine that results in the classic dyskinesias associated with this degenerative disorder. Well, as such, we would expect that dopamine receptor antagonists would result in a Parkinson's-like response. By the same token, a dopamine agonist would also cause dyskinesias, but there would be dyskinesias that are hyperkinetic. Now, let's backtrack a little, and let's just remember that in those pathways, dopamine is critical to allow the initiation of movement. And if it is critical to allow initiation of movement, there is no doubt that its blockade or its loss is going to result in lack of initiation of movement and what we call bradykinesia. Conversely, the agonist that causes dyskinesia would cause the patient to constantly initiate the movement cascades, hence the hyperkinetic dyskinesias of the agonists. Well, this is also explaining why we'll use dopamine agonists to fight Parkinson's and why dopamine blockers will be said to cause pseudo-Parkinsonism or drug-induced Parkinsonism. A second pathway of relevance is one that we actually review initially in the behavioral sciences. It is a situation where the cell body are meso in the midbrain, primarily in what we call the VTA or ventral tegmental area, and the output of these neurons are in limbic structures. You know, limbic structures such as the hippocampus controlling memory, such as potentially the hypothalamus controlling certain aspects of behaviors, but also endocrine regulation, and surely certain nuclei such as the amygdala, which is so important in aggressive type of responses. There are also mesocortical tract leading to frontal cortex, and particularly the prefrontal cortex, a very important spot for drugs of abuse. It is well known now that dopamine causes positive reinforcement. Positive reinforcement means it makes you feel good. It causes you to feel pleasure. As such, any action we do or any chemical we do that causes an increased dopamine in the mesolimbic system will likely result in intense pleasure and a desire to repeat the experience. It is that type of reward effect, that pleasure effect, that we can attribute to drugs of abuse. So that addiction in part is explained by increased dopamine in the mesolimbic pathway, and also in certain of the repetitive behaviors that are observed in psychosis, particularly in the positive symptoms of psychosis. Needless to say, dopamine in those pathways plays major cognitive role in controlling the way we feel, controlling the affect, the way we perceive stimuli. Well, when I'm looking at this, there is no doubt that drugs that increase dopamine would potentially be drugs of abuse, but also drugs that could cause reinforcement and at high doses psychoses. Conversely, a dopamine antagonist would be a drug that decreases cognitive function, doesn't make you feel very good, but could actually combat the symptoms of psychosis. Your biggest problem clinically is how to tell the drug to only block a receptor in mesolimbic pathways without blocking it in nigrostriatal. Or conversely, how to get a drug that stimulates nigrostriatal without stimulating the mesolimbic system. Drugs distribute in the brain and eventually reach both pathways. What is a potentially therapeutic effect of a drug in one pathway would become a side effect through the other pathway. Still really in a way mesolimbic, there are small neurons that leave the median eminence, portion of the hypothalamus, and directly stimulate or inhibit certain pituitary function. Maybe one of the better known effects of dopamine in endocrine is its inhibitory effect on prolactin, to the extent that dopamine agonists, such as a drug like pergolide, can be used in hyperprolactinemic states. Don't forget, prolactinomas are the most common type of pituitary adenoma, and shutting down prolactin would be quite relevant in order to prevent the effect of high prolactin. Dopamine blockers are expected then to cause too much prolactin to be produced. In a male, a dopamine antagonist could result in gynecomastia, in female, in amenorrhea or galactorrhea. If you want to be complete, actually, dopamine not only controls prolactin, but also controls growth hormone. That is why the same dopamine agonists that are used in hyperprolactinemia can also be used in acromegaly or in the management of gigantism. Another effect of dopamine in our CNS is its activation of dopamine receptors in the chemoreceptor trigger zone. The very same stimulation we saw occurring with an opiate. Stimulation of dopamine receptors in chemoreceptor trigger zone always results in increased vomiting. This is why a dopamine agonist is expected to trigger vomiting, whereas a blocker is an important family of antiemetic, strong enough to be used even in vomiting induced by chemo or radiotherapy. To be perfect, I would actually add 2 more pharmacology of dopamine in there. It's all endocrine type of responses. Dopamine actually in the hypothalamus also helps controlling temperature. And the dopamine control of temperature is that in a way of a thermostat. So you should really more worry not so much about stimulating dopamine receptor and making your thermostat work better, but rather blocking dopamine receptor will mess up your temperature regulation. And without that thermostat, you will tend to overheat and develop a hyperthermia type of response. Another effect of dopamine is shared by neurotransmitters such as norepinephrine and serotonin that tend to cause anorexia. This is primarily because of their effect, this time not in anterior or posterior nuclei of hypothalamus which control temperature, but rather medial and lateral nuclei of that important brain area. In these pathways where dopamine and norepinephrine or serotonin are increased, there is a tendency to stop eating. It means drugs that are dopamine agonists will cause weight loss, whereas drugs that are dopamine antagonists will result in significant weight gain. So you see clearly that dopamine should be known for its effect on movement initiation, on reinforcement, euphoria, pleasure, also on endocrine function with inhibition of prolactin and GH, control of temperature and food intake, and finally on the chemoreceptor trigger zone with an effect on vomiting.